The next speaker is Dr. Craig Sinclair, who is the Director of the Cancer Prevention Center of the Cancer Council in Victoria and the head of the WHO Collaborative Center for UV Radiation. We'll be talking about the Australian skin cancer prevention experience.
Thank you very much. And it's terrific to have the opportunity to talk about skin cancer prevention to you all. The context of my presentation is to really instill the lessons learned from implementing a skin cancer prevention program in Australia and how the lessons learned from that experience are applicable to North America and also the key challenges facing us all in the area of public health to do with skin cancer prevention over the next decade, to do with solariums and vitamin D and climate change. I've got no interest to declare. Now, the important thing in terms of context, it is, if I want to talk about skin cancer prevention, you can say, look, this is an Australian issue, not so relevant here to the US. I guess my role here is to dispel some of those myths and talk about skin cancer prevention and its relevance to North America. So to put my home city, Melbourne, in the state of Victoria, which is the southernmost state in the mainland of Australia, it's equivalent in latitude to San Francisco. So it has a bit of a Californian climate. Skin cancer in Australia is a major public health problem. Clearly, we have the highest rates in the world. 2 out of 3 Australians will at some stage in their life develop a skin cancer, and certainly it's a major public health cost. So treatment is certainly a real problem in terms of servicing and cost to the health system. This particular billboard, I think, provides a sort of context of how skin cancer prevention campaigns were created in Australia. This billboard was from about the mid-1980s, which is around the time when we first started what we called the Slip Slop Slap campaign. And as you can see from the billboard, there's this group of people who have what would be considered in today's terms a dark and very dark tan. And that was certainly what was considered to be highly socially desirable back then. The couple on the left there who have what would be considered today probably a more fashionable tan were certainly seen on the outer. The context of this was that a dark and very dark tan when we first started our campaign was highly desirable, and that was clearly leading us to a path of having very high melanoma rates. However, I guess one of the key messages I'm wanting to really instill today is that this is not an Australian issue alone, and I can just look at some US data here in terms of lifetime risk of melanoma in the US, and you can see that it's gone from 1 to 1,500 to 1 in 52, which is quite considerable. But when you start looking at these rates in terms of the rates that we're dealing with in my home state, where this program, which I'm really assessing today and presenting to you, is based on, you can see that the rates for US whites are equivalent to the melanoma rates for Victorian women. So I guess one key point is that this is not an Australian problem by any stretch of the imagination. This is a problem equally, maybe not equally, but certainly a problem should be of concern to the United States as well. So what does a comprehensive skin cancer prevention program look like? This is the program in Victoria, which I'm certainly involved in, and it combines all the broad elements of social marketing, community interventions in workplaces, in general practitioners, in working with local government, a strong paid media component, which is what I'll be presenting shortly, services in schools being critically important, and we've had great success in schools. We have around about 90% of all primary schools in the state have what's called a no hat play in the shade policy, where kids actually have to wear hats as part of the school uniform, and we do a lot of advocacy around sunbeds, which I'll also be talking on. But let's first of all just show you an example of a media campaign which is going to be running this summer, and I could just ask for sound for this too. Thank you.
Tanning is skin cells in trauma, trying to protect themselves from cancer. But one damaged cell can start a melanoma growing, and just 1 millimeter deep it can get into your bloodstream and spread. So even if a melanoma is cut out, the cancer can reappear months or years later, often in your lung, liver or brain. And you haven't even started to burn yet. There's nothing healthy about a tan.
Once again, the hard-hitting messages have been what's been instrumental in motivating behaviour change. We have gone away from the light and easy slip, slop, slap type of campaigns which were prominent in the 1980s to much more harder hitting, and this is just typical of the sort of campaigns that we've been rolling out on a broad population basis. So the key question, have we made a difference? And I guess this is really what my presentation is all about. From an observational point of view, we can certainly demonstrate some changes. This is an example of on the left-hand side, lifesavers, which you typically would see in the beaches around the late 80s. The mobile phone is some indication there, early 90s. That was their uniform. The uniform of lifesavers now are wide-brim hats and long-sleeve shirts, not the great Aussie icon that many people would think. We've seen changes at population levels in terms of shade structures. There would hardly be a swimming pool, a public swimming pool in the state of Victoria that would not have a shade structure over at least the toddler pool. You see shade structures on the beach. Clearly this is some indication, but not the best evidence. The best evidence we've got in terms of are we having impact is looking at skin cancer rates, and I want to touch on basal cell carcinoma rates and then melanoma rates. And you can clearly see here that there are trends showing that there's a decrease in BCC rates in those aged 14 to 39. And we've also seen this in the melanoma rates for those under the age of 50 or under 59, either a levelling off or decrease. And this kind of makes sense. Our SunSmart campaign has been running for around 20 years, probably a bit more. The impact of that skin cancer prevention message would make sense that it would have its greatest impact on the younger age groups who've had the most of their years of their life exposed to that sun protection message. And those in their 60s and 70s may have only had really approximately the last third of their life exposed to the SunSmart message, and those rates are still increasing. But most importantly, we are seeing those rates going down in the younger age groups. Sunburn is also a terrific proxy for impact. And again, looking at this when we first started campaigning in 1988, as our reference year, we've seen that we've been able to decrease melanoma rates to its maximal impact around the mid-1997-98. It has increased again and now back down. This interestingly mirrors the paid media investment that we've had. As soon as we put our foot off the pedal in terms of our paid media exposure, sunburn rates went up. And we've seen this in tanning trends. And this is an important point that I'll come back to. Thomas talked about the economics in terms of New York City and how important that is, and we've also seen that the economics is incredibly important for us to sustain investment in skin cancer prevention. Fortunately, we have really good evidence now that given the high costs of treatment, the sheer numbers of people who are getting treated for skin cancer, prevention is actually a fabulous return in public health investment in terms of dollars. For every dollar invested over a 20-year period, there's a $2.30 return to government. Now, you don't see this very often in public health, to have such a strong return on investment. So from that point of view, it really makes excellent value for money, and it makes a lot of sense that we're investing here. So what are the key lessons we've learned in terms of broad mass media campaigns, social marketing campaigns? Well, we learned that to be successful in terms of at least skin cancer prevention, but this is pretty much universal in public health, you need to be able to have a broad, multifaceted campaign, a broad social marketing context. You need paid media. You can run your community service announcements, but you're not going to have the impact. You need paid investment. And we've known that television is still the most successful method for communication. You need access to consistent resources, so governments have to be in there for the long haul. In our case, they've been funding us for over 20 years. You need a strong home base. In our context, it's to do with the Cancer Council Victoria supporting and funding our efforts. and we need to integrate the research and planning into our program delivery, and we have a very strong research agenda. That's I guess, some key lessons learned. Other key lessons that we've learned, which has been also published, has been that if there is a direct correlation between investment in paid media and behaviour. And really the key lessons to learn out of this, we talked about effective advertising. That's talking about, in lingo, in advertising lingo, it's called TARPs. But the more advertising you spend, the more likelihood that adults will wear hats, that they'll use sunscreen, and there'll be less of their body exposed. And there's a direct linear relationship between investment and changes in behaviour. We haven't reached a peak where we're seeing wastage, where we're spending too much on advertising and seeing not that return on behaviour. The other thing that we've clearly learnt is that due to a randomised control trial conducted in Victoria, where we actually installed 30 shade structures in secondary schools, that adolescents will indeed use shade structures in secondary schools if it's available. We may have great difficulty getting hats on them or getting them to use sunscreen. That seems to go out the window between primary and secondary schools. But certainly we do know that they are and do want to use shade when it's there available. And the other key thing, which I've already touched on, is that it's really critical that we can't take our foot off the pedal. Public health investment, like in skin cancer prevention, as in tobacco control, requires a long-term consideration of investment. And as soon as you put your foot off the pedal, we see regression in behaviour. And we've seen that not only in primary prevention, but we've seen it also in immunisation programs and so forth. It is incredibly important. Health promotion does act like a spring, and as soon as you take your foot off, you're going to get regression. The second part of my presentation is really going to be talking about some of the global issues affecting skin cancer control, and I'll be touching on those three items. First of all, let's look at the issue of vitamin D. Vitamin D has been probably the biggest challenge to those of us working in the area of skin cancer prevention in its entire history. I'm sure each of you in this room will have heard undoubtedly enormous media coverage around the virtues of vitamin D that covers everything from osteoporosis to swine flu to cancer, multiple sclerosis. Some of those elements have terrific evidence, particularly around osteoporosis. We've had reasonably good evidence around colon cancer and vitamin D. There's less evidence around multiple sclerosis and influenza. It's even been attributable to sexual dysfunction, the vitamin D. It seems to be a wonder drug. It's almost too good to be true. But we do have to take it seriously. The key challenge in skin cancer prevention is trying to work out what is actually the optimal level of UV exposure that is actually required to enable us to get sufficient vitamin D to reduce our risks of osteoporosis, yet at the same time not have so much UV to add significantly to our skin cancer risk. It is really the holy grail of evidence that we have yet to obtain to really know what is that optimal level. And that's certainly being a big challenge for us going forward. What we do know, however, is that this increased awareness about the potential virtual benefits of vitamin D and real benefits have having a big impact on people's behaviour. People are hearing that message and are altering their behaviour. Unfortunately, the people who are most altering their behaviour are the sun seekers, particularly teenagers, adolescents who are hearing the vitamin D message and saying, great, I've now got an excuse to spend much longer period outdoors without sunscreen, without wearing hats. This increased awareness about vitamin D is not having the impact on those who are most at risk, such as those who may, for cultural reasons, be covering up, those with very dark skin, those in institutional care. So we have a bit of a public health problem in the sense that people are interpreting this message for their own benefit, not necessarily for good public health reasons. To try and manage this issue of vitamin D and skin cancer prevention, we've introduced right across the country what we call the SunSmart UV alert. So we're now making recommendations when people should be taking the sun protection message during the times of the day and when they should not. So here's an example of stating that people should be recommending that they have sun protection between 9 a.m. and 4:30, and that sun protection outside of those hours is not recommended. And that is really relating to the WHO guidelines of no sun protection up to when the UV index is 3, and then sun protection required when above that, as some way to help balance that message. To date, there is still no evidence to suggest that using sun protection over the SunSmart months or the months of the year when people should be using sun protection is having an impact on their vitamin D levels. Solariums is also been a considerable challenge for us working in the area of public health and skin cancer prevention. And fortunately, there's been quite considerable movement in this area right across the globe. And this is largely due to evidence that's come out of the World Health Organization that has classified exposure from sunbleds as a Group 1 carcinogen, and clearly showing that there is a substantial increased risk for those using sunbeds in terms of melanoma. Here are a list of countries that have banned under 18 access, Brazil being clearly the standout, where in November of last year they have banned sunbeds for cosmetic purposes outright. So there is no sunbeds available in Brazil for cosmetic purposes. And we've seen there that there's other bans that are in train to be implemented next year. I know England and Wales will be implementing a ban of under 18 access in April of next year. Unfortunately, we haven't got this sort of movement happening in North America. I know the FDA are actually looking at this issue and are going to be issuing some recommendations around this area. But certainly North America, I think, is starting to lag behind a bit of certainly the European community in terms of implementing under 18 bans in this area. In Australia, as a result of a number of issues, one in particular, a young woman dying from melanoma in quite public circumstances, whom she stated was due to her solarium use, we have implemented controls which have banned under 18 access. Anyone with a skin type 1, which is someone with typically very fair skin, red hair, so forth, they are also excluded. Training of operators, no health claims able to be made, and a licence fee is applicable for every premise and every machine. So we know where every sunbed is in the state. This has been quite a significant change over the last 2 years in Australia. But the most interesting outcome from this is that there is, in the city of Melbourne, which is around about 3.5 million people, we've seen a 50% reduction in the number of sunbed operators in that city as a result of this legislation and increased awareness. I mean, quite remarkable. The sunbed industry is pretty much going out of business. Fortunately, we don't have the type of strong lobby efforts that occur in North America in the sunbed industry, but certainly we've seen substantial changes there. So in terms of sunbeds, it is really important that we focus on the under 18 bans, because that's where the best evidence appears to be. We can't ban under 18s without also banning unsupervised operations. There needs to be appropriate penalties and checks in places. And we have to make sure, if we are going to be implementing controls in relation to sunbeds, that we don't lead to this perception that sunbeds are somewhat safer, and the industry will use that lever if that's available to them. Lastly, I'm just going to finish on a topical issue to do with climate change. And again, this is another reason why skin cancer should be a public health priority. There is a limited evidence, but it's reasonable to suggest that as the temperature increases due to climate change, people, particularly in the higher latitudes, will have greater opportunity to spend more time outdoors and will likely spend more of that time less exposed. So from that point of view, we anticipate as a result of changes in temperature there will be even more skin cancer cases going forward. Increases in UV will also lead to greater suppression of immunity to infectious diseases and increased eye diseases. So once again, this is an issue which should be considered going forward. So in summary, in the area of skin cancer prevention, we are in a very fortunate situation of knowing what works, what can change people's behaviour, what can lead to changes in skin cancer rates. This is not like obesity, which is incredibly complex. There's a multiple range of levers that you can pull, none of which has great evidence to suggest it's going to reduce obesity going forward. In the area of skin cancer prevention, as we now know in tobacco, we know what has to be done. The key challenge going forward now is to make sure that skin cancer is seen as an important public health issue, and having the will of government and other policymakers to invest in that to make a difference in terms of reducing skin cancer rates into the future. Thank you.
Well, thank you, Craig. Dr. Rosen, if you'll come up. We have about 15 minutes for questions. And while she's coming up, I just wanted to say that this session is so different from the rest of the AACR molecularly oriented sessions that one of the things I think that it is worth exploring is what aspects of research can best inform and help push these measures ahead. So would you just care to comment on that from your perspective?
So I guess one of the things that's making a big change, I think, in British Columbia right now is we've known all along that we had to partner with the medical system to take care of business, but I think that the change that happened 2 years ago when we started to actually move this into a public health model is really crucial. And that means that we're now, the researchers that are involved in social marketing strategies and getting the evidence that we need for Ministry of Health and policy change, that we're actually configured inside of that spectrum, and that we're looking at all of the issues that come underneath population health, equity of access, you know, the whole, joining this whole regime of do we need paid advertisements, how do we sustain systems. Those dialogues, I think, had to happen, and were not happening inside of oral cancer. We're not happening inside of oral health, and they are major barriers to us. So now we have people that are actually the bridge, these people that are the social scientists, that are sitting and they're advising and they're helping us actually move the system forward. And I think this is really a crucial thing that you do not see. You brought this up yourself. You do not see this whole implementation arm swing into practice that knows how to do, that has processes, that has policies, and knows how to take care of business. It's not there, and it's not partnering with us as scientists who are developing technology and are treating the disease. If we're going to have impact, we have to move into the policy sphere, and we need to engage these people that are actually our spokespeople.
So before we go to the first question, did you have a comment on that?
I mean, certainly public health and primary prevention is often the poor cousin in research, and it is really important, certainly from the perspective of myself as a practitioner, to use this research to help leverage changes in how we go about implementing programs. And I think it's great to see some sort of marriage in this context, because without it we can't work separately.
Yes, you.
So I want to thank all the speakers in this session, because in cancer prevention, there's a lot of chest beating that, oh, we can't have an effect, the research is taking slowly, whatever. But I think the talks today really showed that we are much further along than we think in terms of being able to make an impact. I wanted to make a comment specifically, or ask Dr. Rosen, because she really did do a lot of the basic science, the laboratory translational components that then led her to a very different area of influence, the public health arena. And most of us don't have the skill set to go from the bench to a organizational effort. So how did you make that transition, and what words of advice can you give us?
I think I didn't know it at the time, but the public health people told me that I was actually following the frameworks for change, right? And all of the stuff that's happened to us has been with really heavy consultation. It's actually engaging all the stakeholders and saying, okay, what do we need to make the difference? And the people that have really mentored me in this process have been the social scientists, you know, that there is a process that you can follow this through. I understood going into this a lot about the medical system. I understood chemoprevention. I understood biomarkers. I've been playing with them for years, right? But I was really kind of devastated by the fact that we were not having impact, and that we needed to have some way in place to actually explain to people what we were doing and some kind of a framework for change that would allow us to assess the change and move forward. And so it is this whole thing of I think bringing the whole arena of scientists to the system, not just the clinicians, but these other people that are spokespeople to Ministry of Health, and again asking questions about what do you need, what's the fragmentation, and then plugging and playing these people, you know, the people that create devices, plugging them into the medical system where we need a tool that does this, and then bringing the clinicians in and saying, you know, like, you know, does it work for you? And can we, this partnership building, right? And this leads to the ownership. It's the ownership. It's the transfer of ownership and that vision, sustainability.
Let's take the questions 1, 2, and 3. So you're first.
Yeah.
Number 1,
Yeah.
that's you.
Yeah, so I have a comment and a question. And in the comment, I made Eva stand up here. Why I made the comment, because I thought she's going to address this. And I'm a member of the scientific organizing committee chaired by Eva. And, you know, one of the reasons you guys are here is because we wanted you here as part of the spectrum. It's you guys are the reasons why us basic scientists do what we do, because what you're seeing is, you call it cancer, and it is, but it's basically a function of molecular aberrations that arise as a function of differential risk, either intrinsic or environmentally induced. And so we look at it at the molecular level, and, you know, but you guys look at it at the broader level. So it is a spectrum. I'm glad you guys are looking, I don't want to use the word down and up, but I'm glad you guys are looking back at the basic science, because the basic scientists are actually looking at the basic science up to where it links to you guys. So it clearly is a spectrum, and I agree completely. We need to each look sideways to link it, and we'll get synergy out of that. And I just wanted to make that point. The question is, the last speaker mentioned that, you know, the most effective media was television, and a number of individuals that you were targeting, particularly for melanoma, were some of the younger individuals. And, you know, I can't believe I'm saying this in public, but the generation behind me communicates differently. You know, they tweet, they twit, and they text, and they live on the internet, and it's a social network that, you know, I think it's a good thing. And I'm just wondering, have you looked at that and explored it and have found it to be useful or non-useful?
Yes, it's certainly the whole new media, we like to say, is becoming such a more important part of our media strategy. Unfortunately, certainly in public health, it's been impossible to assess its effectiveness. And so we do the tweets, we do try and do the viral campaigning and YouTube and other means of communicating to particularly young people. But the evidence base in terms of seeing what impact you're having on behaviour, television still continues to have the greatest impact. And it's not, and I'm not saying that the others don't have any impact. Television still has the greatest impact in terms of getting the reach that you need to get that population level. The new media can get a broad reach, but it takes an enormous amount of work, and to measure its impact is very difficult. So you do have to work hand in hand with the digital strategy as well as television.
Thank you.
Yes, good morning. My name is Xuehong Zhang from Harvard Medical School. First, I thank you for all the wonderful talk. This section gives me a sense of how the efforts made by different scientists from different areas to the practice of disease prevention. I do have a question regarding the tobacco control for Dr. Tun. Can you offer more insights on the what some of the barriers need to be overcome in order to have better anti-smoking campaign, especially in developing countries, particularly in China? Thank you.
Well, that's another whole hour. But in China, I think the central problem is that it is so profitable for the government. How you change that is really the key question. Elsewhere, I think the Framework Convention on Tobacco Control has helped in bringing a standard set of approaches internationally. Each country is too small to combat the tobacco industry by itself, even if it's not the major source of cigarettes. And so now there is a growing infrastructure of economists who look at the price sensitivity of cigarettes, of people who work with national governments to try to advance taxes and clean air laws, and just that there's so far to go.
My name is Li Mao from University of Maryland Dental School, and this is a wonderful session. I really enjoy very much. Thank you very much for the organizing committee and these speakers. And there's two questions. One is regarding the tobacco control. You know, I personally have very much interest in the area because I work in both lung cancer and neck cancer research. And in terms of in China, I personally wrote a letter to the Prime Minister, try to, look at the experience we have in the States to see whether can give them the guideline of also person willing to participate if they launch the big programs. As you said, it's very difficult for government in China because the stakeholder is the central government for tax reason. But I'm happy to say, very recently, some steps appears to taking place in the major hospitals now. The smoking-free hospital is being implemented. A couple of hospitals I visiting very frequently. I think last month they launched these smoking-free hospital programs in the major cities. It's a good step. I think it's take a long time, but with the pressure from around and with the recognition of the health problem and potential benefit for the population, I think the government probably step slowly but moving toward the right direction. And I have a question for Dr. Ross. And first of all, you should be congratulated for the tremendous work you have done and build this wonderful network. And actually, I'm trying to follow your footsteps to see what we can do here in States. And one of the questions I think it's very important, I try to get a little bit more understanding by your system, is that you have this biopsy service center. And, the wonderful problem I start facing is that the dentist network, they are solo practitioners. And when they see these individuals I don't know how, big British Columbia is, like state of Maryland is not big. I still have a challenge for where the patient get a biopsy. And many of those, they have a transportation issue. I mean, who is going to pay for and how, you get the system works. I mean, what is your capture rate in terms of individual? They should be biopsied.
It's a good question, and I think that's one of the reasons why we've got the surveillance system in place, and we're opening these dialogues with dentists to get a better idea of how many times they don't refer forward or they don't take a biopsy, right? And I don't think we have a good indication on that. I think because we've made clear referral pathways that, if you suspect something, send this person forward, right? So even if you don't take a biopsy, go to these people and they'll accept it. And then we've made coverage inside of the clinics that they will accept them to take the biopsy, right? That's made the transition because that is available to them. So they can use, if they get referred forward into these clinics, the medical system will cover costs for the biopsy, and the registry service does the analysis free. And so we've kind of jury-rigged that together by challenging each of the professions to give a little. But you're constantly with this stuff, and we talked about, you're always plugging holes, you know, and you're always finding a new person to step into the hole to fill that bridge. But I also believe that it's part of ownership of the system, you know, that they own to the fact that they're responsible for that patient. And if they don't refer forward, there's an issue.
So first I'd like to thank AACR and Eva and the organizing committee for making this session possible and for reaching out to what I think is a critical rate-limiting step about actually preventing cancer. And I'd like to thank all of you for staying and despite travel plans. And I'd like to thank the speakers for a delightful section. Thanks a lot.